Here's something that most people don't realize. When you sit in your doctor's office discussing treatment options, there's another party in their room you can't see. And that's your insurance company. They're not just paying the bill, they're determining what option your doctor can actually offer you. Because here's the truth, your doctor doesn't really decide what treatment you get. Your insurance company does. They do it through a system of codes, reimbursements, and approvals that most patients never see. A system designed in the 1980s, based on the medical practices of the 1950s. That still controls what treatment you receive today. And when it comes to a woman's hip pain, this system has a problem. It pays for the treatment that don't work, and it doesn't pay for treatment that does. Why? Because the incentives are literally backwards. The system makes money when you stay in pain, not when you get better. Let's start with the basics. So how does your doctor actually get paid? You show up for an appointment, you check in, you hand over your insurance card. The card gets scanned into the system. The computer checks it. Is this a patient's insurance active? What their coverage and what their deductible status. You see the doctor. They examine you, discuss treatment, and they give recommendations. Then you leave. And behind the scenes, the real process begins. A medical coder, someone you never met, reviews the business documentation. Doctors write notes, what systems you reported, what exams findings that they even documented, and what they assessed, what they plan to do. The coder translates all of this into codes. You get the first diagnostic code, ICD-10. These describe what's wrong with you. The M25.551 is the pain in your right hip. 76.891 other specified of your right lower limb. Then procedure codes, your CPT codes. These describe what the doctor did. So you got the 99213 is the office visit, established patient, 15 minutes. Then you got another code that's 73501, the x-ray, hip, one view. These codes get submitted electronically to your insurance company. The insurance company's computer receives them. It automatically checks, is this patient insurance active? Is this provider in network? Is the diagnostic code valid? Is this procedure code appropriate for the diagnosis? Has the patient met their deductible? Does this require prior authorization? If everything checks out, the insurance approves payment. But here's the key thing. The insurance doesn't pay what the doctor charges. They pay according to a fee schedule. Your doctor bills $180 for the visit. Insurance allows $85. Insurance pays $68, 80% of allowed amount after deductible. Patient pays $17, save 20% insurance. Doctor writes off $9. Difference between billed and allowed. This happens every service, the doctor's revenue is entirely determined by these insurance fees schedules. Not by how much time they spend with you, not by how complex your case is, not by how good the outcome is, just by the codes. And here's where it gets important for you. Some codes reimburse well. Some codes reimburse poorly. Some things don't have codes at all. Let's compare two different approaches to treating your hip pain. Approach A, your standard care. Office visit, 15 minutes. So say code 99213. Establish patient, straightforward. Reimbursement, $85. Doctor orders x-rays of hip. Code 73501. radiological examination of the hip. Reimbursed $45. Total reimbursement for this visit is $130. Time spent, 15 minutes. Revenue per hour is $520. Follow-up visit to review results, which is 10 minutes, say code 99212. That reimbursement is $65. Okay, now we're going to refer you to physical therapy. Referral code, no additional payment. Your PT is authorized 6 sessions, approved automatically. Each PT session is billed by the PT, not your doctor. So now we're going to do code 97110, therapeutic exercise. Say you they reimburse $45 per session. Total PT revenue for 6 sessions is $270. Patient returns after 6 weeks of PT and is still in pain. Doctor orders the MRI. Requires prior authorization, but usually approved after failed PT. So there's another code. MRI hip without contrast. By the way, I recommend with contrast. Try to push for that. Either way, without contrast, they get reimbursement of $350. You follow up to review your MRI, 10 minutes, you get another code sent in, and that's an $85 reimbursement. MRI shows no structural damage, refers to pain management now. Pain management initial visit, you get another code that's reimbursed of $20. They suggest a cortisone shot or injection. Another code, injection, major joint. They get reimbursed $100. Monthly medication management visits, say for the next 12 months. That's $1,020 per year that is reimbursed. So your total first year revenue to healthcare system, so your primary care, $340, physical therapy, $270, imaging, $395, pain management, $300, medication management is $1,020. So your total is $2,330. And the patient, still in pain. Let's go with approach B, comprehensive functional assessment. That's 90 minutes, comprehensive history, including pregnancy history, birth trauma details, postpartum recovery, pain pattern analysis, functional limitations, movement observation. So now we're going to have more code. The first one is the detailed visit. It's reimbursement, say $130. Time spent, 90 minutes. That revenue per hour is only $87. Functional movement assessment. That goes over your core stability testing, your pelvic floor coordination assessment, hip, muscle activation patterns, movement patterns analysis, compensation patterns, identification. Specific CPT code for this assessment, it doesn't exist. But the closest code you could probably use for this would be a physical performance test. And that reimbursement is only $45. But most insurance requires very specific diagnosis to approve this code. Specialized pelvic floor physical therapy. That is about 60 minutes individual sessions. Not in a group, with therapists trained in postpartum biometrics. It's another code, but it's the same code as a regular PT. Reimbursement is the same as a regular PT, $45. But actually need 12 to 16 sessions for a real change. Insurance typically approves only 6 to 8. More sessions require extensive documentation and appeals. Ongoing movement patterns retraining. Teaching the brain new motor patterns. Re-coordinating core and pelvic floors. Retraining muscle, your hip muscle activation. Requires 8 to 12 weeks of consistent work. CPT codes that capture this specifically does not exist. Have to use the same generic therapeutic exercise code. So the total time investment, initial assessment is 90 minutes. The follow-up visit is 45 minutes. Times that by 3. Specialized PT is 60 minutes. Times that by 12. Total clinical hour time or Total clinical time is 17 plus hours. Total reimbursement initial visit is 130. Your follow-up is 390 and your PT session is 540. If, let's just say they're all approved. If that's the case, then that is totaling $1,060. Your revenue per hour is only $62. And the patient, they actually recover. Pain resolves, function returns, no chronic medication needed. Let's put these side by side. Total revenue is $2,330 in year one. Ongoing revenue is $1,020 plus per year. Multiple provider benefits, quick, effective appointments, fits in a 15-minute time slot. No specialized training needed, patient outcome, chronic pain management. Or approach B is the total revenue is $1,060 one time, no ongoing revenue after recovery, single provider or small team, time intensive appointments, requires specialized training, often requires appeals and documentation. Patient outcome, you actually recover. From a pure business perspective, which one makes more sense? A, the standard care generates more than twice the revenue, and it keeps generating revenue year after year. Comprehensive care is one-time revenue. Then the patient is gone. The system financially rewards keeping patients in chronic care. Not intentionally, not because anyone plans it that way, but because of how the codes and reimbursements were structured in the 1980s based on the 1950s model of care. So now let's talk about prior authorization. This is what happens when your doctor wants to order something outside the standard protocol. Things that commonly require prior authorization for your hip pain is your MRI. So that's before trying a 6 weeks physical therapy. More than 6 to 8 physical therapy sessions. Specialized PT, so like your pelvic floor movement analysis. Then you got pain management referrals, any non-standard diagnostic test, certain medication. Here's the process. Doctor decides patient needs an MRI, writes the order. Order goes to the front desk staff. Staff checks it. Does this insurance require prior authorization for the MRI? Answer is almost always yes. Staff member logs it into the insurance company portal, navigates to the multiple screens to find the right one, or the right form, requires information. So the patient's complete medical history, all previous treatments that they tried, results of all previous treatments, specific symptoms and their duration, why each previous treatment failed, why this test is medically necessary, expected results, and how their changed treatment, supporting documentation from medical literature. The staff member has to pull all of this from the medical records, summarize it, and enter it into the form. Time required, say, 30 to 45 minutes per authorization request. Could be longer. Staff is not paid by insurance companies for this time. So who pays the staff time? The doctor's office does. It's overhead. Forms get submitted, goes to an insurance company for reviewers, often not a doctor, sometimes a nurse, sometimes just someone following a checklist. They check, has patient tried conservative care first? Has it been at least 6 weeks? Is there documentation of ongoing symptoms? Does the request follow guidelines? If any box isn't satisfied, denial letter sent to the doctor's office and patient. The reason? Not medically necessary at this time, or conservative care must be attempted first. Insignificant documentation. Now the doctor's office can appeal. Appeal requires even more detailed documentation. Staff members spend another hour writing detailed narrative, pulling specific progress reports, finding supportive research, documenting failed treatments more thoroughly. Sometimes requires peer-to-peer review. Doctor has to call insurance company medical director. Appointment scheduled 2 weeks out. Doctor spends 15 minutes on the phone explaining why their patient needs this test to another doctor who's never seen the patient, who's reading from protocol guidelines, who's financially incented to deny claims. That's how insurance companies control cost, by making the approval process so burdensome that some doctors just give up. So let's look at the timeline. Day 1, doctor orders your MRI. Day 1 to 3, staff submits prior authorization. By day 8, initial denial received. By between day 8 and 10, office submits appeal. By day 18, peer-to-peer review scheduled. By day 21, peer-to-peer occurs. Approval granted. By day 23, MRI scheduled. First available appointment. Hopefully it works with your schedule. Day 35, MRI performed. Total time from doctor order to test being performed is about 5 weeks. Patient waiting in pain this entire time. And sometimes, after all that, final denial. So the patient's options are pay out of pocket for the MRI, which is $800 to $1,200 for a hip MRI, give up on getting the MRI, and file an external appeal. That can take months. Most patients choose option 2. They give up, and this is by decision. Insurance companies count on a certain percentage of people to give up. It's called creating an administrative burden. A McKinsey study found that insurance companies save billions by making the process difficult enough that people don't follow through. Not by denying all claims. That would be illegal. But by making it so time-consuming and complicated that the percentage of people just give up. And the doctor's office calculate this too. Is it worth 3 hours of staff time to fight for a test that reimbursed only $350? If the staff costs $25 an hour, that's $75 in overhead. If the approval rate is only 50%, the expected value is negative. So some offices stop trying for a certain time. They just don't offer them. Or they only offer them to patients who can pay cash, creating a two-tier system. If you can afford to pay out of pocket, you can get comprehensive care. If you're relying on insurance coverage, you get whatever the insurance will easily approve, which is a standard 1950s protocol. Now, let's talk about what happens when conservative treatment fails. You've been in pain for a year. You've tried physical therapy twice. You've tried medication. The pain persists. Your MRI shows something. Maybe small labrum tear. Maybe a slight cartilage thinning. Maybe a bone spur. Ortho shows you the images. See, this area here. That could cause your pain. We could do surgery to fix it. Hip arthroscopic, minimal invasive. 3 small incisions. Camera goes in. Surgery can clean up the tear, shave down the bone spur, smooth out the cartilage. Recovery time 3 to 6 months. Success rate depends on who you ask and what conditions they're treating. Now let's look at the economics of this surgery. Your surgery fees. There's more codes. There's a code for hip arthroscopic with labrum tear. The surgeon is reimbursed about $1,800 to $3,500 depending on your insurance. Actual time is 1 to 2 hours. Then you got the facility fee, whether it's a hospital or surgical center. Oh, there's another code. Multiple codes for OR time, equipment, recovery. Now, the facility reimbursement is $8,000 to $15,000. Oh, wait. Don't forget your anesthesia. That's another code. That reimbursement is about $800 to $1,500. Throwing numbers out there at you. Post-operative physical therapy. You got 8 to 12 weeks of physical therapy after surgery. Oh, wait, that's another code. But it's the same code that we have been using for physical therapy this whole time. So you got $1,080 or $1,620. That's going to be reimbursed because you get 24 to 36 sessions. Follow-up visit with the surgeon. 2 weeks post-op, 6 weeks, 12 weeks, 6 months. Total follow-up revenue is $340. Total reimbursement for hip arthroscopic the surgeon is about, on average, $2,500. The facility on average is about $12,000. Anesthesia, say $1,200. Post-op for physical therapy, roughly $1,350. Your follow-up, say $340. That total cost is $17,390. Now, here's what's interesting. Surgery requires prior authorization, but it's much easier to get approved than the comprehensive conservative care. Why? Because there's a clear documentation path. Patient has pain. Conservative care failed. Imaging shows abnormalities. Surgery indicated per guidelines. All the boxes checked are satisfied. Approval typically happens within 5 to 7 days. Sometimes same day. No peer-to-peer review needed. No lengthy appeals process. Patient out-of-pocket costs, high copays. Insurance pays 80 to 90% of approved amounts. Patient pays, say, $1,500 to $3,000 typically. Now let's compare this to the conservative care that might actually fix the problem without surgery. Comprehensive pelvic floor physical therapy with movement retraining. 16 weeks of one-on-one care with pelvic floor specialists. Total cost is about, let's say, paying out of pocket is $2,000 times 16, so that's roughly $3,200. Insurance covers typical approved 6 to 8 sessions. That's $600. Patient pays out of pocket for remaining 10. That's $2,000 to $2,600. Plus, has to fight for even the initial 6 sessions to be approved for the specialized PT. Prior authorization with specific diagnostic codes. So those codes again. Often denied initially. Regular PT must be tried first, even though regular PT already failed, because it wasn't the right kind of PT for the problem. Appeal process, 3 to 6 weeks. Success rate of the appeal is about 50 to 60%. Many patients give up and either try to pay out of pocket if they can afford it, do without specialized care, end up getting surgery instead. Let's put this side by side. Total cost for surgery is $17,390. Insurance pays about $14,500 to $15,500. Patient pays between $1,500 and $3,000. Your approval process is about 5 to 7 days. Healthcare system revenue is $17,390. Your patient outcome is 60 to 70%. Experience significant improvement. Studies show mixed results for non-structural hip pain. So now let's go to the specialized PT. Total cost is $3,200. Insurance pays $600 to $800 if approved at all. Patient pays between $2,400 to $2,600 out of pocket. Approval process about 3 to 6 weeks, often denied. Healthcare system revenue is only $3,200. Patient outcome is 80 to 85%. Experience significant improvement for functional pattern-based pain. From healthcare system financial perspective, surgery generates more than 5 times the revenue. Surgery is easily approved by insurance. Surgery benefits multiple providers. Surgeon, the facility, the anesthesia, physical therapy. Surgery creates ongoing follow-up revenue. But the conservative care generates less revenue. It is harder to get approved. Benefits only one provider. Ends when patient recovers. The financial incentives are clear. This isn't about doctors being greedy or unethical. It's about how the system is structured to reward certain pathways and certain barriers to others. Research has shown that in regions where reimbursement for surgery is higher, surgery rates are higher, even from conditions where surgery may not be the best first-line option. Economists call this supplier-induced demand. When you pay more for a service, you get more of what that service, regardless of whether it's the optimal treatment or not. Now let's talk about the other common outcome. Long-term medication management. Not everyone is a good surgery candidate. Maybe your imaging doesn't show enough to justify surgery. Maybe you're not willing to take the surgical risks. Maybe you tried surgery and it didn't work. You get referred to a pain management. Pain management is a specialty focused on controlling pain, not fixing the underlying cause. So your first visit, extended interview. You detailed the pain history, pain scale, pain diagrams. Oh, look, we got another code that we got to punch into our lovely computer for our insurance. New patient. Moderate to high complexity. Reimburse maybe $200, $300. Treatment can typically include NSAIDs, stronger than over-the-counter, muscle relaxers, nerve pain medication, sometimes low-dose opioid. Controversial, but it's less common now for that. Monthly medication costs is between $50 to $200. Insurance coverage, usually good for oral medication. So how about injections? Cortisone injections into the hip joint, or bursa. Oh wait, we got another code for that to send to our insurance. Major joint. They get reimbursed about $100 to $150. Frequency can be done every 3 to 4 months if it works, which provides temporary relief if you're lucky, typically 6 to 12 weeks. But still doesn't address the underlying cause. Monthly follow-up visits, management, 15-minute medication management appointments. Oh wait, we got another code to throw at our insurance company. Now, they will get reimbursed $85 per visit, requiring monthly by insurance and the DEA regulations for a controlled substance. Let's calculate annual cost for all of this. Your initial visit is $250. Monthly follow-up times 12, that's $1,020. Quarterly injections times that by 4, $400. Medication is about $150 a month times that by 12, that's $1,800. So total year is $3,470. Now, like I said, all this is just rough numbers, but you're getting the idea. The key thing here is that this continues every year. Year 2 is $3,220, no initial visit. Year 3, $3,220. Year 4, $3,220. Year 5, $3,220. By year 5, your total will be $16,350. And the patient, you're still has pain. Maybe slightly better, managed, but not resolved. Still can't do everything they want to do. Still depend on medication to function. Now compare this to a 16 weeks of specialized pelvic floor physical therapy. That's $320 one time. Patient recovers, no ongoing cost. This system makes more money on chronic management. Significantly more, honestly. Over 5 years, chronic management generates more than 5 times the revenue of curative treatment. And that's not counting potential complications from long-term NSAID use. So you can get, your stomach problems, cardiovascular risk. I mean, the list goes on, which generates additional revenue. Or the secondary cost, physical therapy for other problems caused by altered movement patterns. Mental health treatments for pain-related depression and anxiety. Additional specialist visits. The system is financially optimized for chronic management, not a cure. So why is the system set up this way? It's not a conspiracy. Nobody sat in a room and designed it to keep people in pain. It's the result of historical decisions that made sense at the time, but created perverse incentives. In the 1980s, when Medicare and insurance companies created the CPT code system, they based it on existing medical practices. What existed? The 1950s diagnostic and treatment model. office visits, imaging, surgery, medication management, those got codes. What didn't exist widely in the 1980s is pelvic floor physical therapy, comprehensive movement assessments, functional patterns analysis. Those didn't get dedicated codes, or they got lumped into a generic code with low reimbursement. So now let's fast forward 40 years. These treatments now exist. They're evidence-based. They work. But the reimbursement structure hasn't updated to match it. Why not? Because changing reimbursement codes is a political and economical battle. If you increase reimbursement for one thing, where does that money come from? Insurance companies work with relatively fixed budgets. They're required to pay out around 80 to 85 of premiums in medical claims. That's the law. So if you increase reimbursement for specific or specialized physical therapy, something else has to decrease. Our premiums have to increase. Neither option is politically popular. So the result, reimbursement structures are incredibly sticky. They change very slowly, usually only when forced by legislation. Meanwhile, patients navigate a system where the right treatment isn't covered. The covered treatment doesn't work. Getting anything outside standard protocol approved is a battle, and doctors' hands are tied by what they can practically offer within the system itself. While insurance companies report billions in profits, while the healthcare system generates ever increasing revenue, and patients remain in chronic management, profitable pain. Your hip pain isn't a medical mystery. It's a billing problem. It's an incentive problem. It's a system that financially rewards the wrong outcome because the incentives were built in the 1980s based on the medicine from the 1950s. And changing them requires admitting the system is broken.